Thanks, Emily, and good afternoon. I'm Tasha Powell, the subject matter expert for the upcoming neonatal component and late onset sepsis module. In the past, we provided a broad overview of the late onset sepsis module. However, today our presentation will be more detailed. We'll cover some key elements of the late onset sepsis and meningitis protocol that will include surveillance concepts, event identification, and data validation. For the duration of this presentation, I will be referring to late onset sepsis and LOS interchangeably, as well as meningitis and MEN interchangeably. We have a lot to cover today, so let's get started. During this presentation, we plan to provide an overview of the upcoming neonatal component, provide CDC's rationale and background for bringing late onset sepsis and meningitis under surveillance, define the National Healthcare Safety Network criteria for late onset sepsis and meningitis, and review the data requirements and plans for electronic detection and reporting of late onset sepsis and meningitis numerator and denominator data. So let's provide first a brief overview of the neonatal component. This chart shows the current NHSN surveillance components as well as the future neonatal component. We have patient safety, long-term care, outpatient dialysis, healthcare personnel safety, biovigilance, outpatient procedure component, and in mid-September of this year, we will have the neonatal component available. The first module in the neonatal component will be late onset sepsis and meningitis. There are 4 criteria available that we will discuss in great detail today. The neonatal laboratory confirmed bloodstream infection or NLCBI 1 and 2, and the neonatal laboratory confirmed meningitis or NLCM 1 and 2. As previously stated, the neonatal component will be released mid-September, and the first module for this component will be released on the same day. There will be future modules in this component that may include early onset sepsis and necrotizing enterocolitis events. We have some exciting announcements related to the neonatal component and late onset sepsis meningitis event module. We are proud to announce that the website for the neonatal component is now live. The first module, late onset sepsis and meningitis, can be accessed on this webpage, and a link to the neonatal component page can be found here at the bottom of the screen. Under the late onset sepsis and meningitis event page, you will find our protocol. You will click on the link and the protocol document will appear as seen to the right of the slide. The web page link here has been included at the bottom of the slide. We will be using the NHSN organism list document for this module. We'll be primarily using the all organisms and common commensal tabs here denoted by the red arrows. We also have a self-paced training available now on our website. If you are planning to track late onset sepsis and meningitis events, this will provide an overview of the late onset sepsis and meningitis protocol. The link to the web page can be found at the bottom of this slide. So let's move on to the rationale for the late onset sepsis and meningitis protocol. The rationale for developing this component is that we realize that neonates who are very low birth weight and extremely low gestational age are at high risk for developing many different complications. NHSN wants to be able to capture healthcare-associated infections and complications that develop in these infants. As for late onset sepsis, the studies show that 36% of extremely low gestational age infants develop late onset sepsis, and 21% of very low birth weight infants who survive beyond 3 days of life develop a late onset sepsis event. And 1/3 of late onset sepsis events are not associated with central lines. We also realized that some clinically identified laboratory confirmed bloodstream infections may have been underreported by requiring 2 common commensals and a sign or symptom. The literature tells us that meningitis occurs in 23% of bacteremic infants, and 38% of infants with an organism in the cerebral spinal fluid may not have an organism in the blood. Given those statistics, the CDC began work on this component with the Vermont-Oxford Network and other key stakeholders in 2015. The collaboration was quite extensive, that involved data collection that was completed in 3 healthcare facilities on 300 medical records. The module was developed with electronic data capture in mind. There will be no manual data entry available for this module, and it allows IPs the opportunity to spend time on prevention instead of surveillance and data entry. IPs and facilities will be able to view their data and line listings in order to implement prevention activities. Before we go into detail about the late onset sepsis module, I'd like to just point out some important information. There will be no manual data entry available for this module. You will need an electronic process system to upload your data. This module is a work in progress, and there will be some validation on the facility's part that will include the following. A line listing of events should be validated monthly. If you have no events for the month, you would select no events on your monthly reporting plan. Initially, we recommend a validation process using a synthetic data set to validate the numerator and denominator capture of data, and we'll cover that later in the presentation. First, we want to cover the locations that are eligible for this module. The following locations are eligible for late onset sepsis and meningitis surveillance: Level 2, Level 3 intermediate or step down neonatal intensive care units, Level 3 neonatal intensive care units, Level 4 neonatal intensive care units. And these definitions of these levels of nurseries are defined by the American Academy of Pediatrics, and each facility will define their locations. So there will be a great deal of information on the next few slides, so I just wanted to highlight the capabilities of each of these eligible locations. The Level 2, Level 3 nursery provides a mixed acuity nursery that houses both Level 2 and Level 3 neonates. A Level 2 special care nursery provides care to infants that are greater than or equal to 32 weeks gestation and weighing greater than or equal to 1,500 grams, who have some physiologic immaturity or who are moderately ill and are expected to resolve rapidly. They provide also care to infants that have received care from an intensive care unit. They also stabilize infants that are born before 32 weeks and less than 1,500 grams until transferred to a NICU or Level 3. A Level 3 nursery provides comprehensive care to infants born less than 32 weeks gestation and weighing less than 1,500 grams, and infants that are, regardless of gestational age or birth weight, who have some type of critical illness. They have readily available access to a full range of pediatric subspecialists, and they're also able to perform advanced imaging. We've kind of covered this in the previous slide, but again, the Level 3 nursery provides that comprehensive care to those infants less than 32 weeks gestation, weighing less than 1,500 grams, and any infant, regardless of gestational age or weight, that has a critical illness. They have that access to the pediatric subspecialist and also advanced imaging. A Level 4 nursery is located within a facility that has the capability of providing surgical repair of complex congenital or acquired conditions. They have a full range of pediatric subspecialists, and they also facilitate transfer and provide outreach education. So let's move on to some key terms. An inborn infant is any infant delivered at your facility. An outborn infant is an infant born outside of your facility. So any infant that arrives at your facility in an ambulance is an outborn patient or an infant. The date of event is the collection date of the blood or CSF specimen from which an organism is identified by culture or non-culture based microbiologic testing performed for purposes of clinical diagnosis or treatment. An eligible infant is defined as an inpatient greater than 2 days, housed on a level 2-3, level 3, or level 4 nursery, a birth weight of 401 to 1,500 grams, older than day of life 3 but younger than day of life 121, with the birth date being day of life 1 regardless of the time of birth. An late onset sepsis meningitis event is a laboratory confirmed bloodstream infection or a laboratory confirmed meningitis caused by a fungal or bacterial organism in an eligible neonate who is older than day of life 3 but younger than day of life 121 on the date of event. When you think of these events, I want you to think of them as umbrellas. So there's a late onset sepsis umbrella and a meningitis umbrella. And in the next slide, we'll discuss the two events under the late onset sepsis umbrella. To meet a neonatal laboratory confirmed bloodstream infection event, you must be an eligible infant and have a recognized pathogen or common commensal identified from one or more blood specimens by a culture or non-culture based microbiologic testing, which is used for the purposes of clinical diagnosis or treatment. And under that, under NLCBI, there are two events. There's NLCBI 1, where one or more positive blood specimens with a recognized pathogen, which is specifically a bacterial or fungal organism, which is not on the NHSN common commensal list. And an NLCBI 2, where one or more positive blood specimens with a common commensal, specifically a bacterial organism, which is on the NHSN common commensal list. In addition, you must have a new intravenous antimicrobial agent from Table 5, and it must be initiated during the late onset sepsis meningitis window period on or after day of life 4 and continued for at least 5 calendar days. As an example of an NLCBI event, we have an inborn neonate with a birth weight of 1,000 grams housed in a level 3 nursery, and they have a MRSA positive blood culture on day of life 10. This is an NLCBI 1 event. Under the meningitis umbrella, we have the neonatal laboratory confirmed meningitis event. To meet this criteria, you must be an eligible infant and have a recognized pathogen or common commensal identified from a CSF specimen by culture or non-culture based microbiologic testing, which is performed for the purposes of clinical diagnosis or treatment. There are two specific types of infection. There's NLCM1, where a positive CSF specimen with a recognized pathogen, specifically a bacterial or fungal organism, which is not on the NHSN common commensal list. And then we have an NLCM2, which is a positive CSF specimen with a common commensal, specifically a bacterial organism, which is on the NHSN common commensal list. In addition, a new intravenous antimicrobial agent from Table 5 must be initiated during the late onset sepsis min window period on or after day of life 4 and continued for at least 5 calendar days. As an example of an NLCM event, we have an inborn neonate with a birth weight of 800 grams that is housed in a level 3 nursery and has a Pseudomonas positive cerebral spinal fluid culture on day of life 20. This is an NLCM1 event. An infusion is the introduction of a solution through a blood vessel via a catheter lumen. This may include continuous infusions such as a nutritional fluid or medication, or may include intermittent infusions such as flushes, IV antimicrobial administration, blood transfusions, and also hemodialysis. A central line is an intravascular catheter that terminates at or close to the heart or in one of the great vessels, which is used for infusion, withdrawal of blood, or hemodynamic monitoring. The following are considered great vessels for the purposes of reporting central lines: the aorta, the pulmonary artery, the superior vena cava, inferior vena cava, the brachiocephalic veins, the internal jugular veins, subclavian veins, external iliac veins, common iliac vein, the femoral veins, and the umbilical artery and vein. It is not required to report the presence of a central line in these events. So let's discuss some key concepts. The repeat infection timeframe is a 14-day timeframe during which no new infections of the same type, specifically LOS or meningitis, are reported for the same patient. An infant may have more than one episode of LOS or MEN during a single hospitalization. But there is a 14-day repeat infection timeframe during which no new infection of the same type can be reported. An infant may have an LOS and MEN event during an RIT period, since these are two different infections. Remember those two separate umbrellas. According to the transfer rule, if the date of event occurs on the day of transfer to a receiving facility or the next day, the infection event will be identified by the receiving facility as present on admission. Please note that facilities will not be able to capture post-discharge events. And let's look at a couple of examples. On day of life 5, we have an infant in facility A NICU. On day of life 6, we have an infant transferred from facility A NICU to facility B NICU 1. On day of life 7, the infant is still in facility B NICU 1. Day of life 8, the infant is in facility B NICU 1 and transferred to NICU 2 within the same facility. If day of life 9 is the date of event, the attribution would be to facility B NICU 1 because it is attributed to the location where the infant was first housed the previous calendar day. In our second example, on day of life 5, we have an infant in facility A NICU 1. On day of life 6, the infant is transferred from facility A NICU 1 to facility B NICU 1. If a late onset sepsis occurs on day of life 7, it is present on admission to facility B, and no infection event will be attributed to facility B or facility A, since electronic capture of laboratory results is not possible for the transferring facility. So let's take an even deeper dive into late onset sepsis and meningitis events. But before we talk about that, let's talk about the late onset sepsis and meningitis calculator a little bit. The late onset sepsis meningitis calculator will be used to identify late onset sepsis and meningitis events in denominator eligible infants, both the numerator and denominator respectively. It is a software library that can be integrated into your system, and it's on-premise deployment that can be invoked locally. Now, although the calculator will be identifying both late onset sepsis and meningitis events, I think it's still very important that users still have an understanding of how events will be how events will be identified. So we'll be going through some case studies throughout the next portion of our presentation. But I think it's just very important that you all have that understanding. So let's move on. As previously stated, we have two events under late onset sepsis that include the neonatal laboratory confirmed bloodstream infection 1 or NLCBI 1 and the neonatal laboratory confirmed bloodstream infection 2 or NLCBI 2. The neonatal laboratory confirmed meningitis 1 is an NLCM1 and a neonatal laboratory confirmed meningitis 2 or NLCM2. So let's first review neonatal laboratory confirmed bloodstream infection events. A neonatal laboratory confirmed bloodstream infection is met in an eligible infant with a recognized pathogen, which is not an NHSN common commensal, and it's identified from one or more blood specimens from an infant and tested by a culture or non-culture based microbiologic testing method that is performed for the purposes of clinical diagnosis or treatment. And so we're going to look at our first case study, baby Mila. Baby Mila is an inpatient infant born July 20th at 900 grams. A UVC and UAC are placed. After birth, the patient was transferred to NICU or a level 3 nursery and remained there for the duration of the case study. On July 30th, the patient has a positive MRSA blood culture and vancomycin was administered on the same date. Would the calculator identify an event? I'll give you just a second to ponder that. And we'll look at the rationale on the next slide. The answer is yes. She meets the 401 to 1,500 grams birth weight and location requirement. Remember, she was on a level 3. And she meets the day of life requirement on the date of event. She was a day of life 11 on the date of the positive MRSA blood culture. So on 7/30, baby Mila had a positive blood culture with a recognized pathogen that meets NLCBI1. So the calculator would identify an NLCBI1 in this case. An NLCBI2 or neonatal laboratory confirmed bloodstream infection 2 occurs in an eligible infant when a neonatal common commensal is identified from one or more blood specimens by culture or non-culture based microbiologic testing method and is performed for the purposes of clinical diagnosis or treatment, and there is treatment with one or more new antimicrobial agents that is started and continued for 5 or more calendar days. The late onset sepsis min window period is a 5-day period around the positive common commensal blood or cerebral spinal specimen that includes the 2 days before, the day of, and the 2 days after the late onset sepsis event date. There are some exceptions to this rule in which the late onset sepsis meningitis period may be shortened in cases where the event occurs on day of life 4 or 5. So if the late onset sepsis or meningitis event is on day of life 4, the window period is limited to 3 days that includes the day of the late onset sepsis meningitis event and the 2 days after. And the reason being is because the 2 days before the late onset sepsis event are before day of life 4, and the infant is not eligible for surveillance on those days. Similarly, if the date of event is on day of life 5, then the window period is 4 days and includes the 1 day before the late onset sepsis or min date of event, the late onset sepsis or min date of event, and the 2 days after. This is the list of eligible antimicrobial agents used to meet NLCBI2 and NLCM2. Please note that intravenous medications only are eligible, and these antimicrobials are not eligible to cite an NLCBI1 or an NLCM1. I'm sorry, let me repeat that again. The eligible antimicrobial agents are not required to meet an NLCBI1 or an NLCM1. A new antimicrobial agent must meet all 4 criteria. They must be listed in Table 5 of the late onset sepsis protocol. The agent must be administered intravenously, and the antimicrobial agent must be started on or after day of life 4 and within 2 days before or 2 days after the collection date of the positive blood or cerebral spinal fluid specimen, and was not given to the patient on either of the 2 days preceding the first antimicrobial initiated in the late onset sepsis window period. So let's talk about qualifying antimicrobial days. Qualifying antimicrobial days are days on which a new antimicrobial agent is administered. 1 or more new antimicrobial agents must be continued for at least 5 calendar days. Days between administration of a new antimicrobial agent also count as long as there's no more than 1 calendar day between administration. The 5 calendar day requirement can be met with multiple antimicrobials as long as each antimicrobial was determined to be new. So let's look at a few examples. On the screen, you will see an example of infant C. The Coronium bacterium pyogenes blood culture on day of life 36 creates a June 12th through June 16th late onset sepsis min window period. Because ampicillin was not given in the 2 days preceding the first antimicrobial initiated in the late onset sepsis and meningitis window period and was started within the window period, ampicillin is considered a new antimicrobial agent. Because the ampicillin was continued for 5 days, it meets the 5-day QAD requirement and an NLCBI2 is cited. In this example, we have infant B who has a staph epidermidis positive blood culture on day of life 14 that created a June 12th to June 16th late onset sepsis min window period. Although the vancomycin was continued for 5 days, it is not initiated during the late onset sepsis min window period, so the NLCBI2 event was not met. In our final example, we have infant E. An infant E had a Staphylococcus capitis positive blood culture on June 15th and day of life 14 that created a June 13th through June 17th late onset sepsis min window period. Because ampicillin was not given in the 2 days preceding the first antimicrobial initiated during the late onset sepsis meningitis window period, the ampicillin is considered a new antimicrobial agent. The change to vancomycin within the late onset sepsis min window period can be used to meet the greater than or equal to 5-day QAD requirement and a late onset sepsis or an NLCBI2 event is identified. So let's look at our second case study, Baby John. Baby John is an inborn infant born on August 1st at 1,050 grams. They had a UVC and a UAC placed. The baby was on the level 3 nursery on August 1st and remained housed on that unit for the duration of this case study. On August 17th, the patient had a single coagulase negative blood culture. On August 21st, ampicillin is administered. Would the calculator identify an event? I'll give you just a second to ponder that. The answer would be no. Baby John meets the birth weight requirement, the location requirement, and also the day of life requirement on the date of event. The positive blood culture with coagulase negative staph creates an 8:15 to 8:19 late onset sepsis min window period. However, the ampicillin was not initiated in the 8:15 to 8:19 late onset sepsis window period. So an NLCBI2 is not met, and the late onset sepsis min calculator did not identify an event. Let's look at neonatal laboratory confirmed meningitis events. A neonatal laboratory confirmed meningitis event in an eligible infant is a recognized pathogen which is not on a common commensal list that is identified from a cerebrospinal fluid specimen and tested by culture or non-culture based microbiologic testing for purposes of clinical diagnosis and treatment. Our third case study is an outborn infant named Baby Apple. She was born on March 13th in Facility A, NICU 1, and was transferred to Facility B, NICU 1, a level 3 nursery. Her birth weight is 1,100 grams, and on March 20th, the infant deteriorated. A CSF was collected that was positive for Group B streptococcus. Ampicillin and gentamicin was initiated on March 20th, and received the final dose on March 26. Did the calculator identify an event? In this case, an NLCM1 event is identified. Baby Apple met the birth weight, location, and day of life requirement on the date of event. There is no late onset sepsis men window period, as this is a recognized pathogen. A positive CSF with a recognized pathogen meets NLCM1 on March 20th. A neonatal laboratory confirmed meningitis event occurs in an eligible infant when an NHSN common commensal is identified from a CSF specimen obtained from an infant and tested by culture or non-culture based microbiologic testing for purposes of clinical diagnosis or treatment, and treatment with one or more new antimicrobial agents that are continued for 5 or more calendar days. So let's look at our fourth and final case study on Baby Rocket. Baby Rocket is an inborn infant born June 1st at 740 grams and was transferred to NICU on the date of birth. On June 14th, ampicillin is initiated. On June 16th, a cerebrospinal fluid culture was collected and is positive for coagulase negative staph. Ampicillin is continued and gentamicin is added on June 16th. Ampicillin and or gentamicin was administered June 14th through June 23rd. Did the calculator identify an event in this case? The answer is yes. An NLCM2 event was identified. Baby Rocket met the birth weight, the location, and day of life requirement. The coagulase negative cerebrospinal fluid culture creates a 614 to 618 late onset sepsis men window period, and at least one new antimicrobial was initiated in the late onset sepsis meningitis window period and continued for 5 or more days. As a result, an NLCM2 was met. So we've covered NLCBI 1 and 2 events and NLCM 1 and 2 events. So let's move on to some additional notes related to the protocol. If both an NLCBI and an NLCM are met, both should be reported with the event date reported as the date of the specimen collection. If both a recognized pathogen and a common commensal are isolated from a specimen, you would report the NLCBI1 and the NLCM1. Results obtained from active surveillance culturing do not count towards meeting criteria for either an NLCBI or an NLCM event. Now let's move on to data collection and reporting. The late onset sepsis surveillance protocol is designed to enable use of computer-based algorithms applied to electronic healthcare data sources to identify infants who qualify for late onset sepsis and meningitis numerator and denominator. Late onset sepsis and meningitis numerator and denominator must be submitted to NHSN electronically. Again, reporting manually using an NHSN web interface is not an option. Healthcare facilities must report late onset sepsis and meningitis data to NHSN via an electronic standard known as Clinical Document Architecture, or CDA. The numerator is any positive NLCBI or NLCM event during the surveillance month in an eligible infant. The denominator is based on patient location and includes all eligible infants. Locations include a level 2-3, level 3, and level 4 nursery. Each infant in a location will count one time during the month. if transferred to another location in a calendar month, the infant will count once in the previous location and once in the new location for the month. Here is an example of a manual numerator form. However, please note that this form will not be available on the late onset sepsis meningitis website, as there is no manual capture of data. However, all data elements will be captured electronically. And here's an example of the manual denominator form. And again, this form won't be available on the website. However, we just wanted to kind of show you the elements or the variables that will be collected. You'll be responsible for uploading your events and denominator data via CDA on a monthly basis. The deadline is 1 month from the last date of the month. So for example, if you have September data, that September data will be due on October 31st. You can send your numerator and denominator data in the same file. However, if you choose to submit them separately, you must upload your denominator first, followed by your numerator. I hope that you all are still with me at this point. We have a couple of more topics to cover, and they include data validation, which we'll start with that first. We'll encourage all of our participating facilities to utilize our synthetic data set and the corresponding test cases to validate software capture of numerator and denominator data. So what exactly is a synthetic data set validation? Well, I'm really glad you asked. The process where we have fake data that's processed through a software vendor system to ensure accurate identification of numerator events and also denominator data. The answer key and test plan will be provided as resources for self-evaluation, and this synthetic data set is available to software vendors upon request via email. Before uploading monthly events, you must obtain and review each eligible location's event line listing. If there is a returned event, you must correct the error and re-upload the events via CDA. I've included an example of a line listing here at the bottom of the slide. Data analysis will be different from other NHSN surveillance events. First, our plans are to provide a metric called a crude monthly risk. This is the number of late onset sepsis or MEN events divided by the number of eligible neonates in each location and month. As an example, if you have one event and 20 eligible neonates in a given location in a given month, the crude monthly risk would be 5%. This provides a snapshot per month and is not meant for comparison to other months or locations. The second metric is a cumulative admission risk. The cumulative admission risk is the number of late onset sepsis or MEN events divided by the number of eligible neonatal admissions. As an example, if you have 2 late onset sepsis or MEN events and a total of 50 admissions in a given location, it would be your cumulative admission risk would be 4%. The cumulative admission risk can be aggregated over time and reported monthly, quarterly, semi-annually, or annually. So this metric is where it gets a little bit interesting. It is the third metric, which is called a time to risk analysis or a survival probability. It is the number of neonates without an LOS or MEN event divided by the number of eligible neonates. Suppose you have 24 neonates without an event and 25 infants for a given duration of stay in the NICU. The survival probability would be 96%, which would be 96%. The interesting point would be that we can calculate survival probability for any duration of stay, and it can be used as a survival plot that will provide increasing clarity as we get more information and reporting. With the variables collected, such as gestational age and birth weight and location, we'll be able to provide a variety of data analyses as facilities provide more data. After your data has been submitted into NHSN electronically, the following reports will be readily available for you in the application: the crude monthly risk and the cumulative admission risk. The survival probability will take some time to collect more information on. So at this time, what you see on the screen are the two metrics that will be available to determine prevention activities. In summary, the purpose of the late onset sepsis and meningitis protocol is to track late onset sepsis and meningitis events in very low birth weight infants, those that are between day of life 4 and 120. Late onset sepsis and meningitis will track 4 events: NLCBI1, NLCBI2, NLCM1, and NLCM2. There will be a fully electronic upload of numerator and denominator data using a software vendor system, homegrown software system, or an electronic health record. Facilities are encouraged to validate their numerator information monthly. Facilities will have 2 metrics that can be used to improve infection prevention activities: the crude monthly risk and cumulative admission risk. If you are planning to track and report late onset sepsis and meningitis events, please contact NHSN at cdc.gov and put in the subject line LOS Men Implementation and put it to Tasha Powell's attention. We'd like to support your facility during the development and implementation process. That is the conclusion of my presentation. Do we have any questions? Thank you.